Okay, I'm going to share my screen. Okay. Okay. Which of the following will be most expected physical examination finding over the right lower chest area? Okay, so this is the chest X-ray. You can clearly see on the right side there is a white area. So there's a white opacity here on the right side. Now let's read the question. 66-year-old man comes comes to the office due to increasing shortness of breath. He had a non-productive cough for several months, which he attributes allergy, but also a 9 kg unintentional weight loss over the time. There is no medical history in the 50 years smoking history. Temperature is 36. Blood pressure is 120/80. Chest X-rays. Okay, so what is the diagnosis here? Is it pneumothorax?
Pleural
No.
effusion.
No, it's a
Pleural.
pleural effusion.
It is pleural effusion. Okay, so we have known that whenever there is air, you will always see air as black, and when you have any other thing, whether that effusion tree is due to some blood or it is due to some fluid, it will always seen be as some whitish area. Okay, so in this question, that is a pleural effusion. Okay, and we know the characteristic of pleural effusion. Breath sounds are going to decrease, percussion dull, fragmentus is going to dull. A tracheal deviation will be none if small and away from the site of lesion if large. Now let's see which of the following option is going to be consistent with pleural effusion. Okay, so he is asking the physical examination finding over the right lower chest over the pleural effusion area. Bronchial breath sounds. Bronchial breath sounds are going to be heard in which disease? Bronchial breath sounds.
Pneumonia.
In,
Pneumonia.
in consolidation pneumonia, you are going to hear bronchial breath sounds. Okay, so option A is not the answer. Inspiratory crackles. Crackles are going to be heard in which disease?
Restrictive lung disease, inspiratory.
Yeah. Pulmonary edema too.
Interstitial lung disease.
Yeah, it can be heard in pneumonia as well. Okay, and if they are fine crackles, they can be heard in a interstitial lung disease. Okay, in pulmonary fibrosis. Okay, fine crackles are associated with pulmonary fibrosis. Inspiratory crackles can be heard in pneumonia and in atelectasis. Okay. Okay. Focal monophasic wheeze that can be occurred in a foreign body aspiration, or it can be due to an obstruction due to it can also be heard in asthma as well. Okay. Increased resonance, hyperresonance is heard in which disease? Hyperresonance.
Pneumothorax.
Pneumothorax or emphysema also.
Okay. Okay, so which one do you think is the right answer here? Is it
B.
option B or F?
That was should be B.
Yeah.
Decreased tactile.
B.
Yes, decreased tactile fragmentus. Okay. Okay. It is a pleural effusion, tactile fragmentus. Okay, let's move on to the next question. Which of the following is most likely decreased in this patient? Okay. What are the options? Endotoxin, C-reactive protein, interleukin 1, nitric oxide, vasopressin. Let's first try to diagnose the patient, and then we will. There's a 50-year-old, 54-year-old woman, 2 days history of fever, chills, and severe fatigue. No chronic medical condition. Takes no medicine. Temperature is high. Blood pressure is very low. The patient's left flank is tender to palpation. Okay. Tachycardia, decreased capillary refill, estimated jugular venous pressure of 3 centimeter above the sternal notch. Hemoglobin leukocytes are elevated. Creatinine is elevated. Nitrites are positive. White blood cells on urine analysis are positive. So the following is most likely decreased in this patient. Okay. So what is happening in this patient?
Patient has
Septic.
pyelonephritis because of the left
Six.
flank pain,
So
and now he's in
the patient is in septic shock.
septic
Septic
shock.
Right?
shock.
Yes.
Yeah.
Okay. So the temperature is elevated, blood pressure is down. Okay. Now, what is the cause of that septic shock in this patient?
Look like the E. coli. We got
E.
nitrates
coli
positive.
nitrites are
Yes.
positive.
Nitrites are positive on urine analysis. Most likely, he has a UTI, which becomes complicated, and due to that complication, he right now is facing septic shock. Okay. Okay. Now, which of the following is most likely be decreased in this patient? Okay, decreased in this patient. In septic shock, what happens to the vessels? Does they constrict or does they dilate?
Vessels dilate.
Dilate.
Vessels dilate. Dilate. Okay. So nitric oxide is a dilator or a constrictor?
Dilator.
Dilators.
Vasodilator.
Okay, nitric oxide is a dilator. Okay, interleukin 1 is interleukin 1 is involved in which disease? What is
Fever.
the function of
It's actually
interleukin 1?
fever. For fever.
Temperature. Fever.
Causes
Yes,
fever.
It is involved in temperature, so it is going to be elevated, right?
Elevated.
Because they are acute. These are acute phase cytokines, and they are upregulated. Okay. Okay, so nitric oxide is a vasodilator. Okay, so it is also upregulated. Okay, and we are trying to find which is decreased. Okay, because in this patient there is vasodilation, so that means nitric oxide is in large amounts. Okay. Okay. Now we are C-reactive protein, CRP.
They also
Increase.
Yeah, it is
increased
also acute
Acute phase
phase
immediate.
protein.
Mm.
Okay, so endotoxin.
E. coli is a
Sugar
gram negative,
increase.
so endotoxin
Increase.
will also be increased.
Yes, endotoxin is also going to be increased.
Increased.
Yes.
Endotoxin is a cell wall component of gram negative bacteria. Okay, so in this it is going to be increased. Okay, we are trying to find which is going to be decreased. So we know that in septic shock there is vasodilation. Okay, so that means those proteins are going to be in less amount, which causes vasoconstriction, right? Like nitric oxide is going to be in high amount because it causes vasodilation. What is the function of vasopressin? Is that a
Constrict-
vasoconstrictor or is it a
Constrictor.
vasodilator?
It's a
Vasoconstrictor.
vasoconstrictor.
It is a
Vasoconstrictor. So it will.
vasoconstrictor. So it is going to be in less. That's why we are seeing vasodilation in this patient, right? Okay, vasopressin. Vasodilation, septic shock, nitric oxide, upregulated. Okay, vasopressin is suppressed as due to no. Okay. Okay, let's move on the.
Can we mute ourselves?
A 31-year-old man comes to the office due to progressive dyspnea. Which of the following is the most likely underlying cause of this patient dyspnea? We have seen this question. We have done this question yesterday. There is a digital clubbing. We have done this question yesterday. Why it is again coming? Okay, so what is the answer of this question? We have done this
Yeah.
question yesterday.
The
Yeah, we had
vascular
one
malformations,
Yes, sir.
confirmation.
Diagnosis?
AVM,
Red
Osler-Weber
Rare
Berger
endoscopy.
syndrome.
ectasias.
Hello. Hello.
Which of the following is the most likely cause of this patient findings? Cause of this patient's findings.
I think this question is
This we
also a
also done
repeat.
yesterday,
Yeah.
I think. Yeah.
Probably one.
I am seeing this question. Please don't.
Hello. Dr. Hasnain. Hello.
Yes, yes.
Okay. So I'm just receiving a lot of complaint from students that there is some disturbance, right? So kindly let me request you each and everyone that please those who want to answer raise their hands. Dr. Hassan is going to select those who are about like you who want to participate because we have some students who like are facing a little bit issues with everyone talking all at once, and so please like let's take care of those students who are just doing U word for the first time. Dr. Hassan.
Yes, yes, yes.
Okay.
Okay, so but I'm not focusing on the viewer right now. Okay. Okay, let's solve this. Physical examination of the right lung would most likely show which of the following findings. Follow-up chest X-ray after the procedure. 71-year-old woman, 4 centimeter, irregular, speculated, rounded mass in the upright upper lobe. CT-guided lung biopsy is performed, and follow-up chest X-ray after the procedure is shown. Okay. Um, Okay. So can anyone tell me what is happening in this chest X-ray?
Pneumothorax on the right.
Pneumothorax on the right. You can clearly see the pleural line, and after that pleural line, you can see that all of the peripheral markings are no longer visible, right? You can clearly see that there is a plural line. Okay, and after that plural line, there is no peripheral markings. These are the peripheral marking. These whitish areas are the peripheral markings which are present in the lung tissue. And but you can see that after this line, there is no peripheral markings. That means there is no lung tissue here. That there is only air is here. Okay, so the answer is high pneumothorax. And we know for pneumothorax breath sounds are going to decrease, percussion is going to be hyperresonant, parameters decrease, tracheal deviation either can be none or away if it is tension pneumothorax. So percussion is going to be hyperresonant, right? So A, B, C, and G are removed. Now, now we are left with tactile parameters and breath sounds. What will happen to the tactile parameters?
Decrease.
Decreased.
Decreased. Okay. And what will happen to the breath sounds? What will
Decrease.
happen to the breath sounds? They are going to
Decreased.
be decreased. Okay. They are going to be decreased. Okay. Let's move on to the next one. Shows areas of large fibrotic occlusion in the terminal bronchioles. 42-year-old woman comes to the office with a non-productive cough and worsening shortness of breath with exertion. The patient has a history of primary pulmonary hypertension and underwent lung transplantation 8 months ago. She states she has not missed any clauses of her transplant medications, reveals surgical evidence of her transplant, but flared lungs. Pulmonary function testing demonstrate forced expiratory volume in 1 second is 67% of best previous effort forward remains unchanged. Lung biopsy shows total fibrotic obstruction in the terminal bronchioles. Okay. So can anyone tell me all the abnormal findings in this patient? Select. Okay, so there is a 42-year-old woman. Okay, she has a lung transplant. And what is the duration? 8 months ago. Okay, why that patient has a lung transplant? Because that person has a primary pulmonary hypertension, and due to which the patient goes for a lung transplant. The duration is very important here. 8 months ago. Okay, so it will help you whether it is acute or whether it is chronic. Okay, the second thing is here that now her FEV1 is reduced, forced vital capacity remains largely unchanged. Her forced vital capacity remains largely unchanged, and lung biopsy shows areas of total fibrotic occlusion in the terminal bronchioles only. Does anyone know what is the specific name of this pathology? The name of this pathology is bronchiolitis obliterans. Okay, so it is written in immunology section. Immunology. Microages. Okay. Vaccination, hypersensitivity. Where is in transplant rejections? Okay, here are the transplant rejections. Okay, so it cannot be acute transplant rejection. Why? The duration. Duration is 8 months ago. Okay, so that's why it cannot be acute transplant rejection. Okay, so if you go with COPD, that is a chronic obstructive pulmonary disease. So how are you going to explain that the forced vital capacity is largely unchanged? What will happen to the vital capacity in a COPD patient? It is going to decrease, right?
Decrease.
Yes. So it is cannot be option number B. Ischemia reperfusion injury. What happens in ischemia reperfusion injury? That subtypes of reactive oxygen species are found which causes the lung damage. Okay, but that cannot explain the a ischemia reperfusion injury is a very acute process. Okay, it will not cause the total fibrotic obstruction. Okay, the total fibrotic obstruction in the terminal bronchioles cannot be explained by the ischemia reperfusion injury. Okay, okay, now if we go for the opportunistic infections, okay, that the person has a transplant is a transplant patient, and she is taking a immunosuppressant, and then there can be a very highly likely chance that the patient develops opportunistic infections. But in this case, the findings which we are seeing in this patient cannot be explained by any opportunistic infection. Okay, recurrence of pulmonary hypertension. If there is a recurrence of pulmonary hypertension, we are going to see the hypertrophy of pulmonary arteries. You will never see there is obstruction of terminal bronchioles in pulmonary hypertension. Okay, so the only thing which can explain all of this is chronic transplant rejection. Okay, and in chronic transplant rejection, see, acute is weeks to months, and chronic is months to years. Okay, and what happens? There's a proliferation of vascular parenchymal atrophy, interstitial fibrosis, and there is bronchiolitis obliterans. Okay, this is a type of chronic transplant rejection. Okay, in this you are going to see the obstruction of very small bronchioles. Okay, there is lymphocytic inflammation and destruction of the epithelium of the small airways, and there's a granulation tissue which is going to form in the lumen of the bronchiole, which ultimately results in fibrosis, scarring, and progressive obliteration of the small airways. Okay, chronic transplant rejection, airflow limitation, and bronchiolitis obliterans. Okay, which of the following is the strongest recommendation for patients in a specific population? Okay, in an experiment, what is happening in this experiment that there's a purified elastin is exposed to stimulated neutrophils, which results in the degradation of elastin molecules into smaller peptides. This process can be inhibited by doing serum from healthy volunteers, but not from a specific patient population. Which of the following is the strongest recommendation for this patient in this specific population? So, what is deficient in this specific patient population? Can you tell me what is deficient in this specific patient population?
Antitrypsin.
Yes,
Alpha 1
Of
antitrypsin.
antitrypsin. Yeah.
alpha 1 antitrypsin. Okay, okay, because the alpha 1 antitrypsin is an inhibitor of elastase. Okay, so when it is not present, you will see an increased activity of elastase. Okay, okay, and elastase is released by neutrophil. Alpha 1 antitrypsin released alpha 1 antitrypsin deficiency leads to what disease?
Emphysema.
Emphysema. Okay. And can you tell me in all these options, which one is the biggest is also a risk factor for emphysema?
C. Avoidance of secondhand smoke.
Avoidance of second-hand smoke. Okay, because we know smoking is also a risk factor for emphysema. Okay. Option number C. Sickle cell disease, CD8, increase elastase activity, increase loss of elastic fibers, deficiency of and absence of alpha-1 antitrypsin, antiprotease that inhibits the neutrophil elastase leads to unopposed elastase activity. Okay, it is alpha-1 antitrypsin is a anti-elastase. Okay, so it inhibits the elastase. Okay, and if this is deficient in a patient population, it will lead to increased activity of elastase. Okay, okay. Which of the following most likely predispose the patient to developing the observed histopathological abnormality? Okay, a 34-year-old man is hospitalized due to trauma sustained during a motor vehicle collision. He subsequently develops worsening shortness of breath and confusion and dies despite appropriate management. Autopsy examination shows scattered petechiae on the anterior thorax. Okay. So we are seeing some shortness of breath. Okay. Confusion. Number 2 symptom, confusion. Number 3 symptom, petechiae on the anterior thorax. Okay. And now always see the biopsy or whatever they are giving us. It is of what tissue? Okay. It will help you a lot when you see what is the biopsy they are giving, it is related to what tissue? Microscopy evaluation of his pulmonary vessels reveal the following. Okay, so this is a pulmonary vessels biopsy. It is a microscopic picture of the pulmonary vessels. Okay, so can anyone explain me this picture? What is happening in this picture? No one? Okay, so do you know how does a fat globule appears a on a histology? How does a fat globule appear?
White.
As a
Yes, it will appear as a cleared out as a whitish area.
Hmm.
Okay, because to stain the slide with hematoxylin and the other stain and the eosin stain, you have to wash it with the specific material that is going to filter out the any fatty tissue. Okay, so that's why whenever you see a fat, you will see that as a clear out area. Okay, so this is a area which is due to fat. So we are seeing that in the pulmonary vessel there is some fat globules. Okay, so there are some fat globules as well in this patient. Okay, so any guess what is the diagnosis in this patient?
Fat embolus.
Fat embolism. Can anyone tell me what is the triad of fat embolism? Triad.
sudden shortness of breath, neurological symptoms, as well as petechiae.
Hypoxemia. The patient has hypoxemia. Neurological abnormalities. Our patient has confusion, right? And petechial rash. Our patient has petechial rash as well. Okay. So, and it is associated with long bone fractures and liposuction. Now come back that our patient has petechial rash, our patient has confusion, our patient has all the three things which are specific for fat embolism. And on microscopy, we can also see there are fat globules within the pulmonary vessels. So, which one is going to be the right answer here? Long bone fracture.
Yeah.
Okay, long bone fracture. See, these whitish areas are fat globules. Okay. Okay, long bone fracture or pelvic fracture. Remember, pelvic fracture also leads to. Okay, a 62-year-old is evaluated for shortness of breath during pulmonary function testing. The patient performs a forceful and a complete exhalation after maximal inhalation. The results are compared to a healthy individual the same age and shown in the image below. Which of the following is the okay? Okay, this is a spirometry graph. Okay. Okay, the forced vital capacity in the normal patient, in the normal person. What is the forced vital capacity in the normal person? The amount of air that the person expels. What is the forced vital capacity here? Can anyone tell me? Forced vital capacity in the normal person.
The area under the diagram of normal.
The forced vital, the amount of air, the what is the expired volume? Forced vital capacity is the amount of air that the person expels out in a forceful expiration. Okay, so what is the normal? What is the forced expiratory volume in the normal person? Is it 4 liter? Is it 3 liter? Is it 5 liter? What it is?
5 liters.
I'm thinking of
Yes,
five
yes, sir. It is
liters.
5 liter.
5 liters.
And in the patient,
3 liters.
In the patient, 3 liter. Okay. Now we know what is the forced vital capacity for the normal and for the patient. Okay. Okay. Now to determine whether it is an obstructive disease and a restrictive disease, we have to find the FEV1. VFEV1. Okay. What is the amount of air that is expelled in the first second in the normal person? Amount of air that is expelled in the first second in the normal person.
4.
4 liter. In the normal, it is 4. Okay. Can you tell me what is the amount of air that is expelled in the patient? Amount in the first second, the amount of air that is expelled. In the patient, what is the amount of air that is expelled?
Less than 3.
Less than
Maybe
3.
like,
Very good.
yeah, less than 3, like
Less than 3.
2.8.
Yeah,
Hmm.
2.8, 2.75. Okay, let go with 2.75. Okay, now measure the FeV1 ratio over FVC. Fe, because we know that FeV1 over FVC is decreased in obstructive and normal or increased in restrictive lung disease. Okay, divide 4 by 5. 4 by 5, what is the answer? 4 liter divided by 5 liter. 4 liter by 5 liter, it will give you the ratio of the normal person. It is 0.8, right?
0.8.
Okay, now divide 2.75 by 3, like by 3. 2.75 divided by 3. 2.75 divided by 3. What is the answer? 0.92,
9.2.
right? Okay, and 0.92 is larger than 0.8, right? And in restrictive lung disease, the FeEV1 over FVC is increased, right? Normal or increased. And in obstructive, it is going to decrease. And in our patient, it is increased. So it is a restrictive lung disease. Which one of these is a restrictive lung disease?
Pulmonary fibrosis.
Yes.
Pulmonary hypertension.
Doctor, can you please go through that concept again? I did not understand.
Okay, so see this diagram. First, that is FVC. Okay, FVC is the amount of air that the person can expel with a forceful expiration. In the normal person, the curve becomes flattened at what volume? At the 5 liter. Okay, so FVC is 5 liter. And what is FEV1? It is the amount of air that the person expelled in the first second. See the time scale and then try to find at the 1 second. At 1 second, it expels the 4 liter. Okay, and then you
Okay.
made the ratio 4 by 5, 0.8. Same goes for the. Now do repeat the same thing with the patient. Restrictive,
Okay.
it is 3 liter. Then measure it for the first second. You will get FeV1 for the first second, 2.75. Take the ratios and then compare the ratios, whether it is increased or it is decreased or whether it remains the same. If it is increased, that means it is restrictive. If it is decreased, then that means it is obstructive. Okay?
Okay, got it. So you calculated 2.75 because it was between 2 and 3, the
Yeah,
FEV1.
we just give a rough estimate that it is between 2 and 3.
Okay.
You can either go with 2.7 as well or 2.8 as well. Both of them will give you an answer which is higher than 0.8.
Thank
Okay.
you. Thank you so much.
You can also go with 2.6 as well. That will also give you an answer which is greater than 0.8. Okay.
Yes,
Can you
thank you.
explain one more time? Sorry, I didn't get it.
Okay, first try to measure the, see this photo. First try to measure the FVC. What is FVC? It is the amount of air expelled during a forceful expiration. Okay, See the curve and see where it becomes flattened. Okay, it becomes flattened in this area. So okay, now see the volume at this area. The volume is 5. Okay, so now we have FVC. And now tell me what is FeV1. What is FeV1? Amount of air which is expelled in the first second. Okay, see 1 second and then see at 1 second it is 4 and 1 go there, it is 4 liter here. Okay, now repeat the same thing with the patient. Okay, and then find the ratio. Once you find the ratio, okay, 4 liter by, when you find the ratio, then compare the ratio. Okay, and you will find out whether it is obstructive or restrictive. Okay.
Okay.
Okay, and then and after you find out whether it is obstructive and restrictive, in our case it is restrictive, so we go with option C. Okay.
All right. Okay, got it. Thank you.
Okay. Which of the following condition most likely lead to this patient condition presentation? Okay, so you can clearly see what is happening here. 18-year-old man comes to the emergency department with sudden onset right sided chest pain and dyspnea. Sudden onset, emergency department. Okay, the patient was at home watching a football game on television. His patient abruptly said no. The patient has no respiration. Thin, tall patient, hyper resonant to percussion, and lacks audible breath sounds. Hyper resonant is only in one condition. In which condition the chest will become hyper resonant?
Pneumothorax.
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 Okay, in only one condition it becomes hyper resonant. See, hyper resonant, pneumothorax, tension pneumothorax. And all the other it is dull, dull, dull. Okay. And in the photo as well, you can clearly see that there is a blackish area on which there are no whitish streaks. Okay, that means there is no lung tissue there. Only air is there. Okay, and the lung is collapsed here.
Collapsed lung.
Yes, there's a collapsed lung and there is a pneumothorax here. Okay, very clear blackish area. No whitish lines here. See, there are whitish lines in this that represent the lung tissue, but in this you cannot see any whitish line. Okay, you can see a small area here that is collapsed lung tissue. Okay, so we know that it is pneumothorax, and it is a tall, thin patient, which is also much more common in pneumothorax. Okay.
Marfan syndrome.
Okay. Tall, thin. See, occurs most frequently in tall, thin, young males. Okay. Primary spontaneous pneumothorax due to rupture of subpleural bleb or cyst, occur most frequently in tall, thin, young males associated with tobacco smoking. Okay. So it is a primary spontaneous pneumothorax. Okay. Now comes back to our question. We know it is not a emphysema, right? So it is not A or E, right? So it is not obstructive hyperinflation or compensatory hyperinflation. So what will be the answer in this patient?
Option A then. Apical
subpleural blebs.
Yes, apical subpleural blebs. It is a primary spontaneous pneumothorax due to the rupture of apical subpleural blebs or cysts. Occurs most frequently in tall, thin, young males.
Could you please explain what subpleural blebs are?
Subpleural blebs are like a cyst. These are like small cysts in the lung tissue. When those small cysts ruptures, you will see the leakage of airs. Okay, a leakage of air from the lungs into the intrapleural area, and with the passage of time, the air continues to get accumulated in that area, and then eventually it causes the collapse of the lung tissue. Okay.
Thank you.
Okay, let's move on to the next question. A 12-year-old boy is thought to be brought to the clinic for a follow-up examination. The patient was admitted to a hospital due to known drowning event. Okay, so there's a 12-year-old boy who go which suffered from a non-fatal drowning. Okay, that result in severe acute respiratory distress syndrome. He was intubated, mechanically ventilated for 1 week. Currently feels well, reports mild dyspnea with exertion. Which of the following parameter is most likely increased? Always read the last line very carefully. Okay, see whether it is increased, decreased, or what it is. Okay, compared to a child with normal cardiopulmonary function. Okay, so first comes a, we know that in ARDS, ARDS is the same like the non-cardiogenic pulmonary edema, right? We have discussed this thing many times. Okay, ARDS is the other name of non-cardiogenic pulmonary edema, right? So it's all manifestations are the same like non-cardiogenic pulmonary edema, non-cardiogenic pulmonary edema. And you can also see it occurs in the drowning injuries as well. Okay. Okay. So what will happen to the compliance? What will happen to the compliance? Compliance is going to decrease. Okay, because now there is fluid there, and now you require much more pressure to inflate the lungs, right? So the compliance is going to decrease. Okay. What will happen to the left arterial pressure? We know that the ARDS, it is written in the criteria of the ARDS that the symptoms are not due to heart failure, right? When we read the criteria, diagnosis of exclusion, symptoms of respiratory failure are not due to heart failure. And if they are not due to heart failure, that means the left atrial pressure is going to be normal.
Normal.
Okay. Okay. Now comes to the diffusing capacity. Does the diffusing capacity will increase, or it is going to decrease? The diffusing capacity is going to decrease.
Decrease, yeah.
Okay, it is the diffusing capacity is going to decrease because now you have a very thick layer of fluid there. Okay, which is going to increase what the amount of the distance that needs to be traveled by the oxygen molecules. Okay, so what will happen to the alveolar arterial oxygen difference, AA gradient? What will happen to that? What will happen to the AA gradient?
It will increase.
AA gradient will
Increase.
increase.
Decrease, yeah. Force
AA
vital
gradient
capacity decrease,
is
yeah.
going to decrease. Okay, forced vital capacity is going to decrease.
Decrease, yeah.
Okay, this ARDS. See, there's a fluid there, and due to fluid, the AA gradient is going to increase. Exudative, proliferative, increase the gradient. Which of the following is the most likely? Okay, on the right side, you are seeing a complete whitish area. You are seeing a complete whitish area. So that means that is not pneumothorax, right? We are sure it is not pneumothorax. Okay. So it can be pleural effusion or it can be atelectasis, right? But it cannot be pneumothorax, right? Okay. Can you tell me the trachea, is trachea deviated here?
Yeah.
Yes.
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 Trachea is
To which
dilated.
side? To which side
Right.
trachea is
To the right.
deviated?
To the right side.
Yeah, to the right side. True. You can clearly see the this is trachea here.
Yeah, to the same side.
Yeah, it is deviated uh, to the pathological side, right?
Mm.
That there is a tracheal deviation to the pathological side. Okay, now comes to see. Okay,
The some columns. Mm.
tracheal deviation away from the side of lesion if large. Okay, in pleural effusion, it is going to be away. But in our question, we are saying we can clearly see that trachea is deviated toward the affected side. It is not away from the. It is toward the side of the lesion, and toward the side of lesion happens in which atelectasis. Okay,
Atelectasis. Yeah.
okay. See, you can. It is deviated towards the whitish area, right?
Yeah.
Let's see. Okay. We know that it is not pneumothorax, so option number A is eliminated, right? We know it is not pulmonary fibrosis, right? So option number B is also eliminated. Fluid transudation into interstitial alveolar space. We know it is not pleural effusion or pulmonary edema. Okay, now we are left with D and E. We also know it is not pulmonary embolism, right? This is not pulmonary embolism, right? So option number E is also eliminated. So the only option left with is occlusion of the right
Occlusion of the
mainstem
right
bronchus.
bronchial. Yes.
Yes. Can you tell me
Mhm.
in which disease there is mucus plugging?
Cystic fibrosis.
Yes, in cystic fibrosis and in asthma. Remember
Yes.
this.
Mhm.
Okay,
Mhm.
in asthma as well. Okay, right mainstem bronchus by malignant cell towards the affected side. Okay, let's move on to the next one.
Dr. Husnan had a quick question for the chest X-ray. So the
Yes.
X-ray, so how about if there was a foreign object obstruction? So would it look the same with the tracheal deviation toward the lesion or no?
Yes, if there is a foreign object obstruction, it will look the same because it will also leads to atelectasis. If it is causing the complete right mainstem bronchus obstruction. Okay,
All right.
anything which is going to cause the complete occlusion of the right mainstem bronchus, it will going to look the same. Okay,
All right. Thank you.
because it is causing the atelectasis. Okay, and on physical findings you will see some other signs and symptoms as well. Okay, you are going to see monophasic wheezing, there's asymmetrical chest movements. Okay, there is also possibility that yet the foreign body can also be visualized on the chest x-rays as well, depending upon on the substance used in the making of that a foreign body. Okay. 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 Autopsy findings include heterogeneous lung parenchyma with subpleural dense collagen lymphocyte infiltration intermixed with aerosin. Which of the following is the most likely diagnosis here? 62, 6 month history of progressive exertional dyspnea, occasional cough, no palpitation or tachypnea, chest pain. Okay, 6 months history, past medical history insignificant. He works as an attorney, does not use tobacco, drinks alcohols, continues to progress, dies of respiratory years of his patients, his symptoms continue to progress, and the patient dies of respiratory failure 3 years after the initial clinical visit. Autopsy findings include heterogeneous lung parenchyma with predominantly, autopsy findings are very important. Okay, with predominantly subpleural areas of dense collagen deposition, lymphocytic infiltration, and fibroblast proliferation. Collagen, fibroblast, lymphocyte. Okay, he may has mentioned three things within the autopsy. Okay, let's see. First, let's see alpha 1 antitrypsin deficiency. Alpha 1 antitrypsin deficient people, what is the age of the patient here? 62. And we know alpha 1 antitrypsin deficiency is a genetic condition and it leads to emphysema, right? And the age of the patient at which it develops emphysema symptoms is usually be between 40s to 50s. Okay, it will not be 62-year-old age patient who will die within 3 years due to respiratory failure. Okay, so option number A cannot explain this scenario, right? Now comes to asbestosis. The patient does not have any risk factor which are related to asbestosis. Asbestosis is a type of pneumoconiosis and it is very linked to the occupational history of the patient. Our patient is an attorney who does not use a tobacco and drink alcohol, and none of these is related with asbestosis. Okay. Okay. Now comes to chronic bronchitis. Chronic bronchitis only affects the upper airway tract. Okay, it will affect your bronchus, main stem bronchus. It will not affect the lung parenchyma. Okay, so chronic bronchitis is not the answer. Now comes to option number D and E. Okay, our patient does not have any fever or subacute fever or anything like that. Okay, so you people tell me between D, E, and F, which one is going to be the right answer? The patient has collagen deposition, fibroblast there. Which one is going to be the right answer?
B, chronic hypersensitivity pneumonitis.
In pneumonitis, will you see increased collagen deposition? Will you see increased fibroblast there? What is the function of fibroblast? What does fibroblast do?
So F, idiopathic
Yes,
pulmonary fibrosis.
idiopathic pulmonary fibrosis. Okay. Idiopathic pulmonary fibrosis. Okay, idiopathy associated with multiple involves of honeycomb clumping, and there is written somewhere. Usually interstitial pneumonia, decreased type 1. No, it is written the. No, it is no longer written here. Thought it is written here, but it is not. It is a fibrotic lung disease, and in this you are going to see increased fibroblasts. Okay, so in this you are going to see increased fibrosis here, and on the autopsy finding of this patient we find increased fibrosis. Okay. Okay, let's move on to the next one. See honeycomb pattern, fibroblastic foci, interstitial fibrosis. Fibrosis is most prominent in the subpleural and the perilobular area regions. And in our patient, in autopsy, the fibrosis is present where? At the subpleural area. Okay. Let's move on to the next one. Okay, which of the following is the most here? What is going to be the answer here? We have done this question before. The patient respiratory rate is increased and his work of breathing is minimum at higher respiratory rate. We have done this question before. What is going to be the answer? Higher respiratory rate. In whether in which disease at higher respiratory rate the work of breathing is minimum. In which disease? Tell me. In obstructive lung disease or in restrictive lung disease? In which one we are going to see lower work of breathing at higher respiratory rate?
Restricted lung disease.
In restrictive lung disease, short shallow breaths presents restrictive lung disease. Okay, short shallow breaths. Okay, in restrictive, and which one is the restrictive one here? Is asthma. Okay, sorry, pulmonary fibrosis is the restrictive lung disease. Asthma is the obstructive lung disease. Okay, let's move on to the next one. Okay. Chest X-ray demonstrate. Okay, first see this photo. This photo is the lesions are tender and present predominantly on the anterior surface of the lower extremities. Does anyone know the name of this specific lesion which are tender and present on the anterior surface of lower extremities?
Erythema nodosum.
Erythema. Okay. Now let's see what are the other findings in this patient. Hilar lymph nodes are enlarged. ACE level is elevated. Which are the okay? ACE levels, we have found three findings. It is a 36-year-old woman, arthralgia, nodules, erythema nodosum. There is moderate hepatomegaly, representative skin rash. Okay. So in which disease you are going to see elevated ACE levels? You are going to see hilar lymphadenopathy. You are going to see a erythema nodosum, you are going to see arthralgias. In which disease you are going to see all four of these?
It's sarcoidosis.
In sarcoidosis. Okay, in sarcoidosis, we are going to see erythema nodosum. We are going to see rheumatoid arthritis like arthropathy. We are going to see bilateral hilar lymphadenopathy. Okay. Okay. And the ACE levels are also elevated in which disease? Sarcoidosis. Okay. Which of the following is most likely to be found on the liver biopsy in this patient? What is characteristic for sarcoidosis?
We will see scattered granulomas,
Yes. What type of granulomas?
non-caseating.
Non-caseating granulomas.
Non-caseating granuloma.
Okay. Scattered granulomas. Let's move on to the next one. 67-year-old man abruptly develops severe chest pain and respiratory distress before collapsing. Wait. Okay. Which of the following underlying histopathological changes are most likely to be found in this patient? Okay. Severe chest pain, respiratory distress before collapsing. Find him unresponsive. She cannot be revived despite appropriate resuscitation. Okay, can anyone explain me this photo? This is a gross photo of a lung. Can anyone explain me this?
Droplets.
Doctor, is this subpleural plebs?
Yeah, these are the subpleural blebs, bullas, or the cysts. Okay, and the subpleural blebs and the bullas are found in which disease? The patient age is 67 years old. Okay, let's cover with option number B first. Hemosiderin-laden macrophages with congested air spaces. They are going to be found in which disease? Option number B is going to be found out in which disease?
Heart failure.
Heart
Heart failure.
failure.
Pulmonary
Okay.
edema. Yeah.
Yeah, in heart failure, you are going to see this. Hemosiderin macrophages may be found in pulmonary edema due to heart failure, alveolar hemorrhages. Okay, so and we know it is not pulmonary edema, right? So option number B is eliminated. Intraalveolar septal destruction with airspace enlargement. Okay. First cover option number A. Option number A is consistent with what diagnosis?
Asbestosis.
Asbestosis, and we know the patient in this case it is not asbestosis, right? So option number A is also eliminated. Option number D. Option number D. Multinucleated giant cells surrounding caseating granulomas.
It's tuberculosis.
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 Very good. It is tuberculosis. Okay. Now we are left with option number E. Option number E would be
Pulmonary fibrosis.
yes. Option number E would be pulmonary fibrosis, idiopathic pulmonary fibrosis. And option number C would be intraalveolar septal destruction with airspace enlargement. That is consistent with which disease?
Emphysema.
Emphysema. Emphysema. Alveolar wall destruction. Okay, you will see it occurs in emphysema, alveolar wall destruction. Okay, in emphysema, and due to the emphysema, it forms subpleural blebs and cysts and bulli. And when that cyst or bulli get ruptured, what will happen? Why this patient died? What will happen in this patient?
Pneumothorax.
Pneumothorax due to diseased lung, bulli in emphysema. Okay, what happens? Secondary spontaneous pneumothorax. Okay, there is a formation of bulli in this when the bulli are the larger version of blebs and cysts. Okay, these are the larger versions of blebs and cysts. Okay, when these bullas get ruptured, you are going to see pneumothorax. What type of pneumothorax? Secondary spontaneous pneumothorax. Okay. Bulli, blebs, free floating fragment sputum in large air spaces, metasposes,
This is affecting the upper part. So this is centriacinar.
yes,
Upper. Okay.
it is affecting, yes, peripheral. Centriacinar and panacinar are differentiated on the basis of location. Centriacinar at the central area, right, and the panacinar on the peripheral area. Centriacinar space frequently in the upper, yes, in the upper lobes, yes. It is in the upper lobe, it is centriacinar, okay. And the patient age is very important, okay. Patient age is 67. 67 page. If it is a case of panacinar, then you are going to see that at a much earlier age. Okay, remember this because panacinar is a genetic condition. Okay.
Right. So it will present earlier. Okay.
Yeah, much more earlier. Okay, usually emphysema patients present at the age of after 60. Okay, And if it is present in at a much earlier age, that means the cause is something other than environmental factors. Okay. Which of the following is the most likely cause of the observed finding in this patient? Okay. Okay. 64-year-old man is evaluated for worsening cough. Sixty-four-year-old man is evaluated for worsening cough, shortness of breath, smoke cigarettes, temperature is elevated, blood pressure is a little bit elevated as well. On lung, you can clearly see there is an opacity. Okay, can anyone explain me the what is happening here? Can anyone explain with the chest X-ray? What's the issue here?
Yes, there is a lower lobe opacification is seen in the right lower lobe.
Yes, there is a lower lobe opacification. What is the cause of this lower lobe opacification here? Remember, the patient temperature is elevated. What is going to be the
Pneumonia.
cause? Yes, the cause is pneumonia. Okay, what type of effusion does pneumonia cause?
It's called
Exudative.
exudative, because it's a
Does exudative has high fluid, high protein or low protein?
Hi.
High protein.
High protein. Does exudative have high LDH or low LDH?
High
High
LDH.
LDH.
High LDH. Okay, let's come to the option. Option number E. Mucus gland hyperplasia and inflammation in the large airways is consistent with what diagnosis?
Bronchitis.
Yes, chronic bronchitis. And there is a read index in which we made the ratio of the mucus glands with the whole of the tracts. Okay. Mucus gland hyperplasia and inflammation is consistent with chronic bronchitis. Okay. Excessive fibroblast proliferation, option number C, is consistent with what diagnosis? Option number C, fibroblasts. Fibroblasts
pulmonary
Diagnosis.
and what?
fibrosis.
Fibrosis. So, idiopathic pulmonary fibrosis. Okay. Exaggerated reactivity and inflammation of the airway. Option number B.
Bronchiasthma.
Asthma.
Asthma. Okay. Now we are left with A and D. You have to tell me which one is going to be the right answer.
D.
D. Yes, because it causes exudative, not transudative. Okay. Novarn, it is Novarn pneumonia. They increase the permeability of the capillary pulmonary endothelium and the abundant proteinaceous fluid. Okay. Which of the following histological changes has most likely taken place in this patient lung tissue? Just read the whole question. A 32-year-old hospitalized man is evaluated for new onset shortness of breath and confusion. As admitted 3 days ago following the motor vehicle collision. He is sustained bilateral femur fractures. Okay, so there's a 32-year-old. He has a bilateral femur fractures and a pelvic fracture and a urethral injury. Temperature, there is a low-grade fever. There is hypoxemia. Oxygen is 84%. Person is agitated, disoriented. There's a petechial rash. Okay, there's sinus tachy with no ischemic changes. Which of the following is the histologic changes has most, okay, what is the diagnosis here? All the three things are present here. Fat,
Embolism, pulmonary embolism.
yes, fat embolism, right? So if it is fat embolism, okay, first you have to tell me the option number A is consistent with what diagnosis? Option number A.
Abscess?
Option A, alveolar fluid rich in neutrophils.
ARDS.
Yes, it is present in ARDS. It can be present in aspiration pneumonia as well. Okay. Okay. Prominent option number C. Option number C is consistent with what diagnosis? Interstitial.
With the fibrosis,
Yes.
interstitial fibrosis.
Yes, interstitial fibrosis. Option number D. Red thrombus lodged in the pulmonary artery.
Pulmonary embolism.
Okay, so you are saying it is fat embolism, then why not D is the right answer?
Because it is red thrombus, but
Yes,
in the
because it
shallow
is,
fluid.
yes. Red thrombus is consistent with deep venous thrombosis. Okay.
Yeah.
Okay, very good. Now you have to tell me whether it is B or E. Which one is the right answer?
B.
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 Fat embolism.
The
Okay. Fat microglobules in the pulmonary arteries because it is fat embolism. Right? Long bone fracture, hypoxemia. We have studied multiple times that in fat embolism, long bone fracture, hypoxemia, neurological abnormality, and petechial rash. And all the three things are present in this patient. The patient has a femoral fracture, pelvic fracture, hypoxemia. He is agitated and disorientated. The patient has a petechial rash as well. Okay, let's move on to the next one. We have done this yesterday. Some questions are mixed. I don't know why. Okay, what is the answer for this question? We have solved this question yesterday. Diagnosis fast. What is the diagnosis here?
fibrosis is there, and the answer was the sarcoid. They were asking the histopath abnormalities. So no,
No, see
what they
the
are asking, can I see the question?
I think it
There
was
is
asbestosis.
and where is the pathology here? Where is the pathology? In the lung or in the pleura?
pleura.
In the pleura,
Yeah,
and the pleura
pleura
is thickened here, right? And the thickened pleura is seen in which? Thickened pleura. What is the name of the cancer of pleura?
Mesothelioma.
Mesothelioma. Which of these option is consistent with mesothelioma?
Cytokeratin and calcatrin.
Cytokeratin. We have done this
B.
question yesterday. Yes.
B.
Cytokeratin. Cytokeratin. Okay. We have done this question yesterday. Mesothelioma, malignancy of calretinine and cytokeratin. Okay, almost in all mesotheliomas. Okay, polygonal tumor cells with microvilli, desmosomes, and tiny filaments. Okay, it is showing some questions from yesterday. Which of the following is the most likely present in this patient? Okay, first try to diagnose the patient. What is the name of the symptom? The shortness of breath is exacerbated when the patient lies flat in the bed, and he has to prop himself up with 3 pillows to sleep well at night. What is the name of this specific symptom? That the person cannot sleep well when he's lying flat and he has to prop himself up.
Congested heart failure.
And what is the name of this specific symptom?
Orthopnea.
Orthopnea. Okay, so the patient has a myocardial infarction 2 weeks ago, 2 stents placed, 1 week history of progressive shortness of breath and cough. Blood pressure is 120 by 80, pulse is 92, pulse oximetry 89, with bilateral crackles at the lung base. Why the patient has bilateral crackles and S3 outside and 89%? Why the patient has bilateral crackles? What is the cause?
Pulmonary edema.
Pulmonary edema. Very good. Okay, and now you have to tell me which of these option is consistent with pulmonary edema. What will happen to the lung compliance in pulmonary edema?
Decrease.
Decrease.
Decrease
The
our
lung
surface
compliance is
tension.
going to be decreased. Okay, now you need a much higher force to inflate the lungs. Okay, so the lung compliance is going to be decreased. Okay, it is a left-sided heart failure leading to pulmonary edema. Okay. 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 62-year-old man is found dead in his hotel room. He was traveling for the work and had checked into the hotel night prior. He was traveling. Okay. No other history is available. Autopsy examination is performed, and you can see this is what? A red thrombus. We just solved a question on red thrombus, right? Okay. Which of the following is the most likely inciting event that led to this patient's death? Okay. Red thrombus is formed in which disease? This is a photo of lung tissue.
Pulmonary
Deep vein thrombosis.
Yes, this is a pulmonary embolism due to what?
DVT.
He was traveling. Yes, he was traveling, and due to traveling, there's some stasis of blood which leads to DVT, and then when the thrombus dislodged from there and get into the pulmonary arteries, it causes embolism and then causes obstructive shock, due to which the patient died. Okay, so we know it is not option number A, right? It is not coronary erythematous plaque rupture. The patient does not die from the MI, right? It died from due to pulmonary embolism, right? It is not MI, right? The patient does not has any malignancy. Okay, the patient does not died due to obstructive sleep apnea. Okay, because if it is obstructive sleep apnea, then how are you going to explain this red thrombus? Right? How can you explain this red thrombus? Okay. Okay. So the answer is deep venous femoral vein thrombosis. Okay. Thromboembolism, deep venous
Can you
thrombosis.
repeat? Sure. Yeah, Doc. Can you repeat, please?
Do you want me to repeat?
Yeah, the
Okay.
process.
Okay. Let's see. First is the first clue in that question is that he was traveling to the work. Okay. He was traveling to the work. Okay. Blood clot within the deep vein. So there's a virtue triad for the formation of DVT. The first thing that should be there is stasis. Post-op, long drive, or flight. If this risk factor is there, you can see the formation of DVT. And in our question, you can clearly see in the second line, he has mentioned he was traveling for work and had checked into the hotel the night prior. Okay, so there's going to be some stasis of blood due to this, because we have seen whenever there is stasis of blood, because during long drives and long flights, people usually do not move their legs around, and due to which the blood will stay there. Okay, and when the blood is going to stay at a place for a very long time, thrombosis starting to form at that place. Okay, and in the autopsy finding, you can clearly see that there is a thrombus there's a red thrombus there. Okay, so in the lung tissue there is a red thrombus. Okay, and you can see RBC is found when red thrombus are usually associated with the DVTs. Okay, with the DVTs, there is the formation of red thrombus. You can see this is a red thrombus. This photo is of a red thrombus in the DVT. Okay. Red area shows the filling defect in A. Okay, red arrows. It is a large emboli which causes sudden death due to clot formation. Okay, so this red thrombus cannot be explained because the answer is not a MI. So we eliminate option number A. The malignancy induced a bronchial bleeding. There are no signs of hemoptysis. Okay, and there is no signs of cancer. There are no risk factor for cancers present in this patient. Option number C is not the answer. Malignancy induced bronchial obstruction. It is not an obstructive lung disease. There is a no ventilation defect here. The main defect here is perfusion defect here. Okay, you cannot explain that red thrombus through the option number D. Okay.
Thank you so much. I got it. Thank you.
Okay. Which of the following is the most likely reason for the lack of lung tissue necrosis? We have done this question yesterday, so I will move on to the next one. Okay. The collateral circulation, the bronchial vessels, we have done this question yesterday. I don't know why there's some mixing of questions here. Which of the following is the most likely diagnosis? Okay. Okay, 36-year-old woman, 4-month history of non-productive cough and exertional dyspnea. Her only other medical problem is frequent heartburn, for which she takes over-the-counter antacids. Temperature is 37.1, blood pressure is 126, 6/74, pulse is 88 per minute, respirations are 20, examination shows bilateral crackles and normal heart sounds. Chest imaging shows bilateral interstitial opacities. Bilateral interstitial opacities. Bronchoalveolar lavage reveals 50% of the cells being lymphocytes. Okay. Which of the following is the most likely diagnosis? Okay. So, do you people think that it is pulmonary edema? In pulmonary edema, do you people find out interstitial opacities in pulmonary edema? Does pulmonary edema affect the lung interstitium, or are you going to see a large number of lymphocytes in pulmonary edema? Is any of these two things are consistent with pulmonary edema? Right or wrong?
No.
No, yes, okay, it is not pulmonary edema. Okay. And we also know asthma is also not a disease of interstitium, right?
Yeah. No.
Asthma affects the large airways, right? Okay. Now comes to asbestosis. Does asbestosis cause bilateral interstitial opacities, or it affects the specific lobes, the upper lobes?
Affects the lower lobe.
Yes, maybe said lower lobes, right? It affects specific lobes, right? It does not cause bilateral interstitial opacities. Now we are left with two options: chronic aspiration and hypersensitivity pneumonitis. Okay, let's see.
It's chronic bronchitis, I think.
Hypersensitivity pneumonitis and chronic chronic aspiration. Chronic aspiration leads to what? Chronic aspiration leads to lung abscess, right? Chronic aspiration like gastroesophageal result disease can cause microaspirations, which can lead to a lung abscess. Okay, in hypersensitivity pneumonitis, it is a type 3 or 4 hypersensitivity reaction. And the cells which are involved in type 3 and 4 are lymphocytes, right? Chronically leads to irreversible fibrosis with non-cascading granulomas, alveolar septal thickening, and traction bronchiectasis. Okay, it is written in the, and the chronic aspiration is aspiration pneumonitis. Okay, in aspiration pneumonitis, you are not going to see increased number of lymphocytes. Okay, you are going to see increased number of lymphocytes on only hypersensitivity pneumonitis. Okay. Immunological response to inhaled antigen, abrupt onset fever, chills, cough, chronically progressive cough, diffuse reticular interstitial opacities, restrictive pattern, high relative lymphocyte count, lymphocytic infiltrate, poorly formed non-caseating granulomas, remove the antigen exposure. Bird fencer's lung due to diffuse disease. Okay. Okay.
What is the answer again, doctor? I didn't catch it.
What did you say? Can you repeat your question?
What do you, what the answer? Okay, I personally no answers. Thank you.
Hypersensitivity pneumonitis. Hypersensitivity, not chronic aspiration. Okay.
Doctor, I have a doubt.
Yes.
You said it's that hypersensitivity pneumonitis is associated with actinomyces.
Yes, it is associated with actinomyces and aspergillus as well. Usually it is found in farmers and bird fencers. Okay, and in
But
these conditions.
okay.
Yes,
But
yes.
my doubt was actinomyces prefers cold thing or how is it thriving in the lung? We read it's like associated with cold environment or something.
Actinomyces, I think so. It is present. Actinomyces is an anaerobe. It is not acid fast, and it is normally found in your oral, reproductive, and GI flora.
Okay,
Okay.
okay, okay. Thank you, thank you. Sorry.
Okay.
Yeah, thank you.
Okay. And there's one more thing I want to see if it is written here. There's something like aspiration pneumonia. Aspiration it is going to pneumonia. This is the if is the chronic aspiration leads to oropharyngeal or gastric contents leading to pulmonary infection, dysphagia, invasive tubes, aspiration pneumonitis. Okay. Let's move on to the next question. Acute radiation-induced lung injury is suspected. A 60-year-old woman is brought to the hospital due to progressive shortness of breath and cough for 2 weeks. He was diagnosed with right breast and then completed radiation therapy. After the radiation therapy, he completed radiation therapy 6 weeks ago. Okay, remember the duration. After the radiation therapy, there is 93% on room air. There are inspiratory crackles over the lung, right lung interiorly. The lungs are otherwise clear to auscultation. There is ground glass opacities in the right lung where radiation was delivered. Acute radiation-induced lung injury is suspected. And which one of these following are you going to find out in acute radiation-induced lung injuries? Hemosiderin-laden macrophages are seen in what disease? Hemosiderin-laden macrophages.
Heart failure.
Heart failure. Okay, necrotizing vasculitis. I don't know whether you have just read necrotizing vasculitis. Does any one of you know necrotizing vasculitis occurs in
Yes.
which disease?
Could that be in
Yeah.
Pan?
It's Wegener's granulomatosis.
Yes. It occurs in Wegener syndrome. Okay.
How about Pan, Dr. Hasnan?
Hmm?
Pan, polydosis polyarthritis nodosa.
Yes. It also occurs in that. Okay. Now we are left with alveolar hyaline membranes and neutrophilic abscess. Okay. Let's read something about acute induced radiation induced lung injury. Radiation induced lung injury associated with pro-inflammatory cytokine release, TNF alpha, interleukin 1, interleukin C. Most be asymptomatic, but most common symptoms are dry cough and dyspnea. Acute radiation pneumonitis develop within 3 to 12 weeks, and fibrosis after 6 to 12 months. In the acute phase, there is an exudative phase. Okay, if there is exudative phase, you are going to see radiation pneumonitis. Okay, and during the exudative phase, you are going to see increased protein or less protein. In exudative,
Increase.
increased protein. Okay, can you tell me any other disease in which we also see increased protein in the alveoli?
Malignancy can also cause the exudative.
Yes, malignancy also called exudative. Yes, malignancy. Okay. In the pulmonary, in the alveoli, I'm not asking about the pleural effusion. I'm asking about the in the alveoli, not the pleural cavity.
ARDS, alveolar.
ARDS. We have
ARDS.
read another name for ARDS. What is that
Highlight.
name? Hyaline membranes. Because
High.
whenever there is an increased protein, they take the shape of hyaline membranes. Okay, like the onion rings appearance. Okay, the answer is alveolar. It only in the acute phase. That's why the duration is important. Because if it is chronic radiation-induced lung injury, then it is going to be fibrosis is going to be there. Okay, in the acute phase, you will going to see exudative alveolitis. Okay, in which you are going to see the leakage of protein-rich fluid there, and the formation of hyaline membranes. Okay, and it occurs in the first 3 to 12 weeks. Okay, radiation pneumonitis, same like ARDS, you are going to see is hyaline membranes. Okay, a protein-rich fluid is going to be there. And in that, if it is a longer duration, 6 to 12 months, then you are going to see fibrosis. Okay. Which of the following is the most likely etiology of this patient diagnosis? Just read the question. Hmm. 17-year-old boy, emergency department due to hemoptysis and severe respiratory distress. The patient has been on several oral antibiotics for pneumonia over the past week and has required numerous similar treatments in the past. She has been coughing up blood for the past week. Okay, blood pressure is 90 by 60 and pulse is 120 per minute. Respiration is 42. Diffusely reduced airflow rates. Gaseous red blood is produced while coughing during the examination. Despite aggressive treatment, the patient ultimately expires. Okay, so there's hemoptysis, there's a large amount of blood is leaking, and due to which the patient goes into a shock, and eventually he dies from that shock. Okay, and other than that, we can also see. Okay, can anyone tell me what is happening in this chest, in this lung gross photo? Can anyone tell me?
Like red hepatization. Is this?
Does that look like a bronchiectasis?
Yes, you can see that the airways are very dilated. See, the airways are very dilated. In all the other photos we have seen of the chest, you will not see such dilated airways. Right? You will not see.
Cystic fibrosis, maybe.
Yes, it can be due to cystic fibrosis. Just give me a second. Okay. Okay. Okay, so you can clearly see that airways are very dilated. In all the other photos we have seen, the airways are not this dilated. Let's see the other photos. If there is any photo which is see in this, see the size of the airways. They are not this much dilated. See in this whole chest, in the chest tissue, you will not, in the lung tissue, you will not see that much dilated airways. There, see the size of the airways. They are not this much dilated, right? But in this photo, see the size of the airways. Okay. See the size of airways in this photo. They are very much dilated. And due to that dilation, you are seeing some kind of bleeding also in this. And why there is bleeding here, there is hemoptysis here. That's what we have to find out. What is going to be the diagnosis here? Okay. Formation of fistula, hemorrhage from a highly vascular endobronchial tumor. What is the age? 17 years. Hemoptysis. Okay, has been hospitalized for pneumonia in the past, has pneumonia in the past. Okay, and you can also see that the patient has a history of pneumonia for the over the past as well. Okay, the patient has a history of pneumonia. Okay, let's open bronchiectasis. Okay, characterized by chronic cough, daily purulent symptom is sputum production, most commonly associated with cystic fibrosis. Often have pulmonary infections, recurrent pulmonary infections, airway dilation, and bronchial thickening, which we are seeing in our question, that there are bronchial thickening and airway dilation in the patient. Okay, there is a permanently dilated airways, dilated and thickened airways. Okay, initial result of a pulmonary infection combined with obstruction and impaired clearance. Okay, and due to which the patient now has a massive hemoptysis. Okay. Okay, so you have to tell me the massive hemoptysis which we are seeing in this patient is coming from the bleeding of which arteries? Is it coming from the bronchial arteries, or is it coming from the pulmonary arteries? The massive hemoptysis, the bleeding which we are seeing, is it coming from bronchial arteries or is it coming from pulmonary arteries?
Bronchial.
Bronchial
Yes, it is
arteries.
coming from the bronchial arteries. Okay, because the pulmonary because the pulmonary circulation pressure is low, and bronchial circulation has high pressure because they are connected to the systemic circulation. Okay, pulmonary circulation is a low pressure circulation area. Okay, and the bronchial circulation is connected to the e- is connected to the systemic circulation. Okay, bronchial arteries arise from where? From the aorta, right? And that's why they are connected to a high pressure flow system. So there's a much higher chance of bleeding from a high pressure artery as compared to a low pressure artery. Okay, so that's why we see bleeding from bronchial arteries as compared to pulmonary artery. What is the pressure in aorta? 120, right? 120 by 80. And what is the pressure in the pulmonary artery? Much less than aorta. Okay, it is, I think so, from 30 to 8. It is something like that. Okay, it is a low pressure flow system, and the systemic circulation is a much higher pressure flow system. Okay, and if there's a higher pressure, then that means there's a higher chance of bleeding there. Okay, so we know it is bronchiectasis. Now we have confirmed that the diagnosis is bronchiectasis, and the cause of hemoptysis is bleeding from bronchial arteries, not from the pulmonary arteries, because bronchial arteries are connected to a high pressure system as compared to pulmonary arteries, which are connected to a low pressure system. Okay. So the answer in this question is going to be
A.
A. Yes, the answer is going to be A. See, this is the normal lung tissue. This is a bronchiectasis tissue. Thick and dilated bronchus. There is mucus plugging and the size is very enlarged. They are enlarged bronchus. Okay. Bronchial artery hypertrophy, airway inflammation, high pressure, bronchial circulation. Okay. Let's move on to the next question. Okay. An 18-year-old man is evaluated for recurrent episodes of. Okay, an 18-year-old man is evaluated for recurrent episodes of shortness of breath, wheezing, runny nose. Mm, mm. What is the answer here? We have done this question yesterday as well. What is the answer here?
Yes, we have done yesterday. A. Histamine.
Yes.
Type 1 hypersensitivity reaction. Okay. Type 1 hyper. I have explained this question yesterday as well. Okay. Which of the following pathological process is most likely associated with this patient's finding? Analysis of several large cuboidal cells under revealed decreasing number of granules containing parallel stacks of membrane lamella. Okay, which of the following pathological, okay, which of the cells of the lung are cuboidal? Can you name the name of the cells which are cuboidal?
Club cells.
Type 2 pneumocystic.
Type 2 pneumocytes. A. Type 2 pneumocytes are cuboidal. Okay, they have two functions. Secrete surfactant from where? From the lamellar bodies. Okay, from the lamellar bodies. And what he is saying in this, they are cuboidal cells in which there are decreased number of granules containing lamellar bodies. What does that mean? That the type 2 pneumocytes have less surfactant, right? And if we have less surfactant, what will happen? If we
Head
have,
neck disease.
yes, and that neonatal respiratory distress, what will happen? Does the lungs will be the lungs
Collapse. Yes,
collapse? Okay.
surfactant reduce the surface tension. So
Yes,
that's why deficiency leads to increased tension.
because surfactant is related to the reducing the surface tension, and when you have less surfactant, you are going to see alveolar collapse, lung collapse. Okay, so that's why we have NRDS, ARDS. In all of these, the surfactant becomes less, and due to which we see lung collapse. Okay, option number A would be the answer if the diagnosis is emphysema. Option number B is going to be the answer if the diagnosis is
As
asthma.
Asthma.
Okay. Option number E is going to be the answer if the diagnosis is.
Chronic
Bronchitis.
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 Okay. Option number E is going to be the answer if the diagnosis is.
Pulmonary
E.
emboli.
Yes. So we are left with only option number D. So this is
Excuse me, sir, if he asked in the bronchioles, that maybe, it will be the club cells. I picked later, he was asking about the alveolar cells.
alveolar cells. Yes. Yes.
Alveolus type 2, and if in bronchioles, then might be the answer will be club cells.
But the club cell does not have lamellar bodies.
Yeah, club cell secrete some part of surfactant, but they not have lamina body. Yeah, this is the clue also. Thank you.
Which of the following cells types likely contributed the most to the patient's decline in the pulmonary function? Okay, let's see what is the diagnosis here. From the PFTs, tell me whether it is obstructive or restrictive. From the PFTs. It is obstructive or restrictive?
Obstructive. Obstructive.
Obstructive lung disease. Okay, a 63-year-old woman comes to the office due to slowly progressive dyspnea on exertion and cough productive of white yellow sputum of the past several years. She has a history of rheumatoid arthritis. Pack of cigarettes daily for 40 years. Bilateral expiratory wheezing. Chest X-ray reveals hyperinflated lungs. Diagnosis. What is the
COPD.
diagnosis?
Obstructive lung pathology, COPD.
The diagnosis is emphysema, right? The patient has hyperinflated lungs, expiratory wheezing, and the patient has a history of smoking. Okay, and we have known what are the three cells which are involved in emphysema in COPD. Three cells. What are the name of the
Neutrophils,
three cells?
macrophage, and
Neutrophils, macrophage, and
CD8.
Neutrophils.
CD8.
CD8.
So what will be the answer here?
Neutrophils.
Neutrophils.
Neutrophils. Okay. Okay, in this you can see CD8 plus T cells, neutrophils, and macrophages are involved in emphysema pathology. And there is increased lung hyperlucency and there is hyperinflation. All of them are going to be seen in emphysema. Okay, so move on to the next one. Okay, with the patient nasal mucosa is most likely to demonstrate which of the following? So it is again question from the previous one. Okay, tell me which one is
Yesterday,
the
from
answer.
yesterday, yes.
Yes, so what is
Cystic
going to be the
fibrosis.
answer?
Cystic fibrosis and the
Diagnosis
diagnosis.
is cystic fibrosis, and because it is nasal mucosa, we have to tell about the airway glands. How does the chloride channel acts in the airway glands? Okay, and what will be the answer?
D.
The
D.
increased sodium absorption. Very good. People have done your homework. Very good. Okay, 32-year-old woman comes to the emergency department with lightheadedness and shortness of breath, which started while shopping at a supermarket. During the last 6 months, she had increased shortness of breath and had to adjust her daily activities. The patient has no other medical problems, does not use tobacco, alcohol, BMI is 25. Her initial the patient put that she feels fine. She dies a month later. She dies a month later, and on her autopsy, this is its autopsy finding. Which of the following is the most likely type? The patient is a female, age
Right
32.
ventricular hypertrophy. Yeah.
Yeah, you can clearly see there is a right ventricular hypertrophy is here. And the patient dies due to that right ventricular hypertrophy. Okay. And the patient has, before she died, has lightheadedness and shortness of breath. Okay. Which of the following is the most likely diagnosis here?
E.
Pulmonary arterial hypertension.
Pulmonary arterial hypertension, not essential hypertension, because if it is essential, we will not going to see only specifically right ventricular hypertrophy. Okay, you will also see left ventricular hypertrophy. If it is dilated cardiomyopathy, you will see membranes, the walls of the heart to be thinned out, right? Okay, if it is bicuspid aortic valve with a you will see left ventricular hypertrophy, right? If it is MI, you will not see hypertrophy. Okay. Wolf Parkinson White syndrome can also does not explain the hypertrophy of the heart muscles. Okay. The only answer left is pulmonary arterial hypertension. Okay. Which of the following symptom is the most likely cause for this patient's symptoms? The patient has recent onset headache and dyspnea, had a puffy face, persistent dry cough, does not have any neck or shoulder pain, has no other medical problem, shows symmetrical facial swelling and conjunctival edema. Dilated veins are noted over his neck and upper trunk. Peripheral
Which,
strength and
yes,
sensation are intact. What is the
this from
diagnosis?
us yesterday.
You also did
This was done.
Yeah, this is
SVC,
also from yesterday. What is the diagnosis in this question?
SVC obstruction because of mediastinal
Superior, yes,
mass.
bilateral swelling, facial.
Yes, and so the diagnosis is
Mediastinal mass causing obstruction of SVC.
superior vena cava syndrome. Okay, and that is due to the mediastinal mass. Which of the following electrolyte disturbance is most likely responsible for this patient confoundings? Okay. So the swimming boy with a sunken fontanelle and mucous membrane, 1 month. Okay, this was also from yesterday. What's the answer for this one? This was also from yesterday.
Yes, it was done.
What is the answer? Diagnosis is cystic fibrosis, and due to cystic fibrosis, what will happen?
Hyponatremia.
Hyponatremia.
Yes,
Hyponatremia.
because when you lose large amount of sweat, you lose two things: sodium plus chloride. So you will going to see hypochloremia and hyponatremia. No, so this is not from yesterday. The development of this patient mucosal lesion most closely resembles which of the following disease process? 56-year-old man comes to the office after 2 episodes of low volume hemoptysis and describes the episode as streaks of blood in the sputum. The last several and more probably in the he also receives several infection.
Barrett's esophagus.
Yes. What is happening in this patient? Microscopic examination of the bronchial mucosa reveals patch of stratified squamous epithelium. And when you study Barrett esophagus in the gastro, you will find out that in Barrett esophagus, specialized intestinal metaplasia, replacement of non-keratinized stratified squamous epithelium with intestinal non-ciliated columnar with goblet cells. Okay, this happens in the Barrett esophagus. Okay, and in the question he is also telling us the bronchial mucosa reveals patches of stratified squamous epithelium. Okay, so the due to irritation, the bronchial epithelium has changed its nature. Usually, the normal bronchi are lined by what lining? Pseudostratified ciliated columnar cells. But due to chronic irritation in Barrett esophagus, there is a chronic irritation by the gastric acid. In this case, there is a chronic irritation by the smoke. So the epithelium changes into a much more resistant form. Okay, so it can bear the damage. So the resistant form is the stratified squamous epithelium. Okay, so it is the same like in the Barrett esophagus. Okay, normal epithelium, metaplasia. Okay, normal has a pseudostratified, and to save itself from the damage, it changes into a much more resistant form.
Dr. Hasnan, quick question. So,
yes,
for the previous question, pseudostratified squamous epithelium is the normal mucosal layer.
Pseudostratified ciliated columnar epithelium is the normal.
Okay. And then due to the smoking irritation, it has been converted to stratified squamous epithelium?
Yes, it is converted into stratified squamous epithelium due to the continuous exposure to the smoke. And that is the same thing which happens in the Barrett esophagus. In Barrett esophagus, there is a chronic irritation due to the gastric acid, and due to which the epithelium changes into a much more resistant form. Okay.
All right. So that would be from squamous, which is the normal mucosal layer, right? Squamous epithelium with the intestinal epithelium?
Yes.
All right, thank you.
Okay, we have done this. The next question is also done yesterday. And in this question, the main thing is this thing. Remember this?
Surgical
What is
and
this?
subcutaneous emphysema.
Yes. That there is air in the subcutaneous area, right? And what will be the answer in this case? Subcutaneous crepitus.
Doctor, I have a question with that metaplasia.
Yes.
Will it be opposite? Because in Barrett's, it was esophagus is supposed to have like your columnar.
Opposite, but the process is the same. That the membrane changes from one to the other one. Okay.
Okay, but it will be opposite. Okay,
yes.
okay.
In there is a non-stratified squamous. It changes into the intestinal epithelium, which is non-ciliated
Columnar.
columnar with goblet cells. Okay, but there is a
Yes,
change in
yes.
epithelium.
Yeah, it's adapting, so change. Okay, okay. Thank you.
Protection against which of the following is most likely to lower this patient risk for lung cancer? Okay. Protection against which of the following can
I think E is the answer because
Radon
Okay.
gas.
because um
It's common in basements.
yeah,
Radon C can
basement.
cause the pleural malignancy and is present in the
Hmm.
basement of the buildings.
Yes, risk factors include tobacco smoking, secondhand smoke, radiation, environmental exposure. What is in the environmental exposure? Radon, asbestosis, pulmonary fibrosis, and family history. So, what would be the answer in this case?
E.
E, the radon gas. Okay, we have just said
Yeah.
And mostly
E
it's
is the
released in the
radon gas.
basement buildings.
Yeah, it is also written in general pathology as well that it can lead to the cancer. Okay, radon gas. Okay, the bird antigens will lead to what disease? The bird antigens.
Hypersensitivity pneumonitis.
Hypersensitivity pneumonitis. Okay, the bird antigens. Okay, the mold spores can lead to what? Mold spores. Also, hypersensitivity pneumonitis. Okay, let's move on to the next one. Okay. Which of the following is the most likely cause of this patient abnormal blood gas findings? Fever and confusion, 2 days history of fever confusion, from accelerators. So the patient, I think so. Have we done this question yesterday or
Yeah,
not?
it's yeah.
Okay, so the diagnosis in this case is diagnosis. What is the diagnosis here?
B1, impaired mitochondria.
What is the diagnosis in this question? Diagnosis. The diagnosis is
Septicemia.
yes.
Yeah.
Yeah, the diagnosis is septicemia, okay, which is leading to sepsis, okay. And in sepsis, we know that MvO2 is increased. It's in this case, the MvO2 is 87% as compared to the normal 65 to 70%. And now he's asking why the MvO2 is increased. Why the cells does not extract oxygen from the blood, okay. And the answer for that is because they are no longer using the oxygen, and due to and oxygen is used where? In the electron transport chain. Okay, and because now oxygen is no longer be used there, we are seeing increased lactate levels. Why increased lactate levels? Because now only the glycolysis is the only source for the production of ATP. Okay, and for the glycolysis to keep on running, you requires a continuous supply of NAD plus. And how do you get NAD plus? By converting the pyruvate into lactate. It will regenerate the NAD plus. Okay. Sepsis. It's most likely to be normal in this patient. Okay, we haven't done this before. Okay, 32-year-old, vomiting, severe abdominal pain, nausea, heavy alcohol use, admitted for acute pancreatitis. Okay, serum lipase is 2392. The patient is admitted, antiemetic with subsequent improvement in the symptoms. Vital signs remain stable. On the second day, the patient has progressive shortness. Okay, the patient has hypoxemia. Chest X-ray reveals new bilateral infiltrates. The patient has pancreatitis, and the pancreatitis is due to the heavy alcohol use. So, can anyone explain what is happening in this patient?
ARDS due to
Yeah.
Yes, the patient has
pancreatitis.
ARDS. What are the 4 criteria of the ARDS?
Acute onset, exclusion of the cardiac lesion, bilateral patches, and increase of AO gradient.
Yes, increase the PaPO to FiO2 ratio.
PaPF2 ratio.
Yes, okay. So it is ARDS. Going to see ARDS. So these are the four.
Can you repeat the four? Yeah, okay, okay.
Respiratory failure within 1 week of alveolar insult. You are going to see hypoxemia. There's abnormal chest X-ray, bilateral lung opacities which are present in this patient. There's hypoxemia which is also present in this patient. And the fourth one is symptoms of respiratory failure are not due to heart failure or fluid overload. And you can see the causes. In causes, you can see there is pancreatitis as well. Okay. Okay, now comes back to the question. Which of the following is most likely to be normal? What will happen to the capillary permeability in ARDS?
Increased.
Capillary permeability is going to be increased. Lung compliance.
Decrease. Compliance will decrease.
Very good. Work of breathing.
Increased.
Ventilation perfusion matching.
Also
Increased.
increase. No, ventilation
Perfusion matching.
decrease.
Not
Matching is
decrease.
decreased.
Decrease.
Remember this. Remember mismatch or matching. What the specific word they are using. Okay. So the only thing which is going to be normal here is pulmonary capillary wedge pressure, because
Yes.
we have learned that the fourth point, symptoms of respiratory failure are not due to heart failure or fluid overload. Because the symptoms are not due to heart failure, that means the pulmonary capillary wedge pressure is going to be normal, right? Okay. Okay.
Also is from yesterday. I think D. Lung
Hyperinflated
condition.
lung,
Yes.
obstructive lung.
COPD and patient. Yes.
The patient is a COPD patient, 65-year-old, 4 respiratory and smoked half a pack cigarette for 30 years. Breath sounds are diffusely decreased. Chest rate increased lucency. Okay. So total lung in obstructive lung condition, total lung capacity increases, right? Forced vital capacity decreases, right? And residual volume increases, right?
Increases.
Okay, we also did this yesterday. What what are these cells? Granulocytes.
Eosinophils.
And eosinophils are involved in what?
Helminthic destruction.
Helminthic destruction, in the killing of parasites, in asthma, in allergy, and in Which of the following autopsy finding most likely to be present in this patient?
Also ARDS due to pancreatitis.
Diagnosis: ARDS, cause pancreatitis. We can see
Pancreatitis.
there is elevated serum amylase lipase, which occurs in when in pancreatitis.
Pancreatitis.
And due to pancreatitis, we are seeing severe abdominal pain associated with nausea and vomiting. Okay, and the pancreatitis is due to heavy alcohol use in this patient. And on chest X-ray, we are seeing crackles bilaterally, which is consistent with ARDS. Diffuse patch infiltrates bilaterally, ARDS. Patient fails to improve with 100% oxygen and dies 4 days later. Within 1 week of respiratory insult, there is respiratory failure, which is also consistent with ARDS. And we have learned the other name of ARDS is alveolar hyaline membranes. Alveolar hyaline membranes. Intraalveolar hyaline membranes. Okay, just give me 10 minutes. Just give me a minute. I will make one more block. I will make one more block, okay, of 10 questions.
Block of 10 questions is okay then.
Okay.
Yeah.
How many questions, doctor?
Yes, I'm making one more block.
40 questions?
No, 10 questions. I will try to make.
Oh, all right. Okay.
Just give me one. Uh, Can you see my screen is visible, right? Okay, so I made a 10, 12 questions block. And after this, our pathology, patho, and pathophysiology is almost done. Okay. Which of the following sets of plural findings are we going to find here? 62-year-old man, okay, plural findings. So that's mean we have to decide whether it is exudative or transudative. Once we have decided that it is exudative or transudative, then we can answer this question. Let's see, and to decide whether it is exudative or transudative, we have to see the cause here. Okay, let's try to find the cause of the pleural effusion here. Okay, 62-year-old man comes to the emergency department due to a 2-week history of worsening shortness of breath. A reports feeling dyspnea while lying flat and has been reports feeling dyspnea while lying flat and has been sleeping upright in his recliner. Okay, let's see the whole question. Jugular venous distension is also present. Okay, decreased breath sound and dullness to percussion. Okay. On physical examination, there is JVD, decreased breath sound, pitting edema on the bilateral lower extremities. Chest X-ray shows cardiomegaly and bilateral pleural effusion. Serum protein is 6, serum LDH is 60. Okay, what is the cause here? What is the cause of pleural effusion here?
It's the heart failure.
Heart failure.
It is the heart failure. That's why we have shortness of breath. We have orthopnea here, which is a symptom very specific for bilateral for the pulmonary edema due to the pleural effusion due to heart failure. Okay, we have bilateral pitting edema, we have cardiomegaly. All of these can be explained by due to heart failure. Okay, and in heart failure, the effusion is exudative or transudative?
Transudative.
Transudative. Okay. Okay. Now comes to the ratio. Serum protein is 6. Serum LDH is 60. Okay. If it is transudative, protein is going to be high or low? Protein is going to be high or low?
Low. Low.
Low.
Option D and E are eliminated. LDH is going to be high or low?
Low. Low. Low.
Yeah. LDH is also an enzyme. It is going to be low. So the right answer is going to be A, right? Because all these are eliminated. Okay. Glucose is going to be remains the same. Glucose is going to be low when? Glucose is going to be low in which condition?
Bacterial something.
When bacterial
Yeah, so there's a
infection.
bacterial or if any living organism is involved, like TB or bacteria. Okay. "25-year-old man with cystic fibrosis comes to the clinic with follow-up appointment." Okay. Let me show you where it is. From this two also low glucose. So I cannot see your question when you are writing them in the chat. Okay. If you have any question, please ask me directly. Okay. Okay. You can see that fluid LDH or serum LDH is greater than 0.6. LDH is also an enzyme, and every enzyme is a protein, right? So it is going to be high in exudative. Pleural fluid protein over serum protein should be greater than 0.5 in exudative. Okay. And because our effusion is transudative due to the heart failure, right? It is transudative. Okay, let's come to the second question. 25-year-old man.
And Dr. Hassan, quick question. So for LDH, you said that for transudative, it's going to be lower than, it's going to be low than, do we have to specify the numbers or lower
If you
than?
want to go, if you want to see the numbers, it should be less than the serum LDH by 0.6. Like pleural fluid LDH should not be higher than the 2/3 of the upper limit of the normal serum LDH. If it is greater than 2/3 of the upper limits, then that means like if the serum LDH level is 6 and the pleural fluid LDH should be less than 4. Okay. It should be
So
less
we're
than
not
4.
comparing it with the protein, right? It's just the serum and the fluid itself.
Yes, it should be less than that. Okay.
Okay, thank you.
Okay. Okay. A 25-year-old man with cystic fibrosis comes to the clinic for a routine follow-up appointment. The patient has had multiple hospital admissions over the last few years for pulmonary exacerbations. Pulmonary function testing will most likely reveal which of the following tests. Okay, first you have to decide whether cystic fibrosis is a restrictive lung disease or a obstructive lung disease. You have to tell me.
It's obstructive.
Obstructive
It
lung
is
disease.
it is obstructive lung disease. In obstructive, what will in obstructive? Okay, in obstructive, total lung capacity is going to increase. Residual volume is going to increase. Functional residual capacity increase. Total lung capacity increase. FeE1, FVC both are going to decrease, and the ratio is also going to decrease. Now tell me, total lung capacity increase, right?
Yes.
A and B are eliminated.
Yep.
FeV1 or FVC ratio is going to decrease.
Ratio.
Option number E is also eliminated. We are left with C and D. FVC is going to be decreased, and the residual volume is going to be increased, right? So option number D is the right answer. Cystic fibrosis is a obstructive lung disease. Okay. Bronchitis, asthma, bronchiectasis. In bronchiectasis, which is an obstructive lung disease, most commonly is associated with what? Cystic fibrosis. Okay, so cystic fibrosis is also obstructive. Okay. Okay, which of the following is most likely effect of this? Later. Okay, so what is the diagnosis here? Diagnosis.
ARDS.
ARDS. The patient experienced dyspnea and hypoxemia due to the patient has a acute, and the ARDS in this patient is due to acute pancreatitis. Okay. Okay, and he in ARDS you will always see bilateral infiltrate. Okay, so the patient has a bilateral infiltrates. Okay, due to and after the acute pancreatitis, and the patient's condition progressively deteriorates, and we started mechanical ventilation, and on mechanical ventilation we give PEEP, positive end expiratory pressure, okay, of 10. Why we give PEEP? Because the lungs has the highest tendency to collapse at the end of the expiration. Okay, so because the lung has the highest tendency to collapse at the end of the expiration, so if we maintain a positive pressure inside the lungs, so due to which the lungs will no longer collapse, because
Increase intrapulmonary shunting.
because it will decrease the pressure. It will decrease the pressure in the intrapleural area, because it will increase the pressure within the lung cavity. Okay. Okay. Now comes to is that how does the PEEP helps in this condition? Does the PEEP increases the alveolar pressure or is decreases the alveolar pressure? The PEEP
Increases.
yes, because you are giving pressure within the lungs by giving air inside the lungs with a specific amount of pressure. So it will increase the pressure inside the lungs. So the alveoli does not collapse. Okay, it will keep them inflated. Okay. Yes, this is increased PEEP keeps the alveoli open during the expiration. Okay, it will keep the alveoli open. Okay, we give him in ARDS. Okay, decreased alveolar pressure knock. Okay, is PEEP increases the intrapulmonary shunting? What will happen if the shunting increases? Does the condition improves or deteriorate?
Deteriorate.
Deteriorate.
And yeah, the condition will deteriorate. Okay, but the PEEP will improve the condition. Okay, it will reduce the shunting. Okay, we have done one question on shunting yesterday regarding the ARDS, that PEEP reduces the shunting, right? And that's how it helps in this condition. Because in this option number D, it is written increase intrapulmonary shunting. That means it is wrong. Okay, we are left with three options: B, C, and E. Okay. So does it? What will happen to the intrapleural pressure?
Increased.
That
Intrapleural
will
pressure.
increase.
Yes,
Yeah,
it
if
is.
we put the PEEP,
Mhm.
intrathoracic pressure will increase, and also it will increase the intrapleural pressure, or not
Yes.
change. In other words,
Mm.
Yes.
Hmm.
Okay. So which one we are left with two options, C and E.
Increased
Minute
functional
ventilation
residual
depends upon
capacity.
the tidal volume and
Respiratory
respiratory
rate.
rate.
Mm.
That's why, yes,
And
SW.
in ventilator we know that tidal volume is an independent thing which does not depend upon PEEP, right? Tidal volume is an entirely independent thing. Okay, so PEEP does not affect the tidal volume or respiratory rate. You can control both of these things independently of the PEEP pressure. Okay, so the increased minute ventilation is also not the answer here. How does the PEEP increases the functional residual capacity? How does it
because
increase the functional
because
residual
increase
capacity?
the residual volume because of end expiratory there is more alveoli filled with the air, and definitely
Yes,
it's
by
the capacity
making
of
the
the residual
alveoli
volume.
open. Yes,
Yes.
because by making the alveoli open, it will increases, keeps the alveoli open during the expiration. Now, because more alveoli are not taking part in the whole expiration inspiration process. Okay, in this way, it increases the functional residual capacity by increasing the number of the alveoli which are taking part in whole respiratory cycle. Okay.
Doctor, I did not understand. How did we rule out E, the last option?
Increased minute ventilation. Minute ventilation depends upon two things: respiratory rate and tidal volume. And when a person is on ventilator, both of these findings are independent of the are independent things which does not depend upon PEEP. By increasing the PEEP, that does not mean you increase the respiratory rate or decrease the respiratory rate, you increase the tidal volume or or in, or decrease the tidal volume. Both of these things can be controlled independently, and changing the PEEP does not affect either of them. Okay, and
Okay.
both of these
Yeah.
things control the minute ventilation. Okay.
Thank you. Here.
Okay. Which of the following is the most likely cause of patient dyspnea here? These are the options. Oh. Okay, firstly, the spirometry results. Everything is normal in spirometry. Okay, everything is normal in spirometry. That means option number B.
No,
Yes, option number B cannot be the answer, right?
no.
Yes.
Because if it is B, then that cannot be normal, right?
Mhm.
Okay, now we are left with A, C, D, and E. Okay, let's read the whole question. Progressive exertional dyspnea and fatigue, painful episodes of bluish discoloration of fingers and toes that are triggered by cold exposure and improve with rewarming. Medical history is significant for gastroesophageal reflux disease. There is skin tightening over the fingers. Oral aperture is small. Scattered telangiectasia over the lips. Increased intensity of S2. Increase intensity of S2. Okay, over the upper left sternal border. Lungs are clear to auscultate with normal air movement and no crackles. The abdomen is soft with mild hepatomegaly. There is bilateral lower pitting edema. Chest X-ray reveals no abnormality. Chest X-ray reveals no abnormality. Okay. Okay. Do you think chest wall restriction can be the answer?
No.
No.
No, because there is normal air entry and normal air movement. The air movements are normal. Okay. Chest wall restriction is not the answer. Okay. Now comes to pericardial constriction, pulmonary valve stenosis, and pulmonary artery narrowing. Okay. Do you think option number C is the answer?
No.
No,
No. No.
Why? Why?
because there is also mentioned that there is increase of S2, in the left sternum. In pericardial effusion, there is decrease all the heart sounds, muffled heart sounds.
Very good. We
Yes.
are going to see muffled heart sound, right? Okay. Okay, we are left with D and E. Both of them can cause loud S2 sound over the upper left sternal border. Okay. Okay, but how are you going to differentiate whether it is D or E? Okay. Do you know what condition is this patient is suffering from?
Yes, it's the systemic sclerosis.
Yes,
Systemic
it is a
sclerosis.
systemic sclerosis.
Yes.
Actually, this is not written in Pulmo, it is written in MSK. So don't worry.
All the findings of the crest findings are there, which is the
Yes.
limited scleroderma.
There is a Raynaud phenomena. That's why we see discoloration of skin. There is GERD syndrome, esophageal, there is telangiectasia, right? There is, okay, and all of the, there is limited skin involvement confined to fingers and face, which due to which there is a sclerosis of skin manifesting as puffed out skin, okay, without wrinkles and fingertip pitting, okay, and the key two things which see in this are either interstitial fibrosis and the other is pulmonary hypertension. But we know that there is no fibrosis here in this question because the PFTs are normal. That's why we eliminated B. Okay. Now we know that it is systemic sclerosis. Okay. That's why the patient, this is Raynaud phenomena. Okay. This is tightening of the skin also can be explained. Telangiectasias are now explained why this is happening. The GERD is also now explained why it is happening. Now every symptom in this patient is explained. Okay. So the right answer is pulmonary
Z.
D.
pulmonary
Arterial
hypertension.
hypertension.
Yes, because we have seen that either it is hypertension and other is interstitial fibrosis. Okay. And because there is no fibrosis, the only answer left is pulmonary hypertension. Okay. Because pulmonary stenosis cannot explain the valve stenosis cannot explain the systemic sclerosis findings. Okay. That's why option number E is not the right answer. Okay. It cannot explain all the other findings. Okay. Let's move on to the next one. Which of the following is the most likely involved in the 34-year-old episodic dyspnea, wheezing, episodic, and chest tightness. Okay.
asthma.
Does not assume works as an automatic protein painting stops. 2-week vacation to Arizona. The patient celebrated about a month ago during a 2-week vacation to Arizona, but reappeared within a few days to his return. Lungs are clear to auscultation with normal air movement. The FEV over FVC ratio is normal. Okay, chest radiograph reveals no abnormality. Okay, so all of these symptoms can be explained. Can option number C is the right answer? C. Option number C. Can option number C be the right answer?
No.
Yes,
Why?
no,
No.
no.
Because spirometry findings then will not see, we will not see FeV1 over FVC 81%, right? That is the
Yeah.
normal thing. And and an emphysema is a obstructive lung disease, and you are going to see less ratio of this, less than 80%. Is option number D is the right answer?
No.
Option number D represent which disease?
Pulmonary hypertension.
Pulmonary hypertension.
Pulmonary
Primary.
hypertension. And pulmonary hypertension cannot explain the episodic wheezing and shortness of breath, right? Okay. So which one is the right answer? A,
It's
B,
the
or E? Which one is the
A.
right answer?
A.
A. Because
A.
our
Yes, A.
condition is asthma.
Paint, yes. Asthma, you know.
Yes. Optional asthma. This patient respiratory symptoms are most likely due to the okay, first read the question. Remove 56-year-old man with a history of hypertension is brought to the emergency department due to 3 days of dysuria and back pain.
Biceps shock. Mm.
So what is happening in this patient?
Septic shock, UTI due to
Septic
the
shock.
pyelonephrosis.
Septic shock.
Septic
No.
shock.
Coli,
The
yes.
patient develops septic shock due to what?
Pyelonephrosis,
Pyelonephritis.
UTI.
E.
Yes,
coli
UTI
Pyelonephritis.
leading to
and E.
complication.
coli.
Okay.
UTI
Okay.
induced.
Okay. So first there is UTI. UTI gets complicated. Due to complication, it gets sepsis. Now, after sepsis, what happens in this patient? Why the patient becomes hypoxic and requires mechanical ventilation? What is the why the patient requires
Plus, sepsis also cause ARDS.
Yeah. Yes.
ARDS? Sepsis is the most common cause of ARDS. Sepsis is the most common cause of ARDS. Sepsis most common. Okay, is the most common cause of ARDS. Okay, we know it is not sarcoidosis, right? It is not sarcoidosis, then option number C is not the right answer. We know it is not asthma, then option number D is not the right answer. We know it is not a pulmonary embolism, right? Then option number E is not the right answer. It is not Wagner syndrome. So the only answer left is alpha. Fluid accumulation in the alveolar space. ARDS. Okay. 62-year-old man comes to weight loss, cough, hemoptysis, poorly controlled diabetes, COPD treated with bronchodilators, oral corticoids, shows pulmonary infiltrates and the area of cavitation in the right upper lobe. Sputum microscopy shows acid-fast bacilli. Acid-fast bacilli mean
Tuberculosis bacillus.
acid-fast bacilli means tuberculosis. Okay. Okay. The location of the cavitation is
Upper lobe.
Upper lobe,
upper lobe.
secondary
Upper
tuberculosis.
lobe.
Secondary.
Okay, so we know that the location is very important in diagnosing whether it is primary or secondary. When the location is in the upper lobe, then it is secondary or primary.
It's secondary.
Secondary.
Upper lobe is secondary.
Secondary.
Upper lobe is secondary. Tuberculosis
also-
can be usually upper lobe.
Cavitary.
Okay, and why it gets reactivated in this patient due to poorly controlled diabetes and due to oral steroids.
Steroids, yeah.
Okay, so what would be the right answer in this?
C.
C.
C reactivation.
Yes, due to reactivation from an old infection.
Infection. Yeah.
Okay. It is not the first time, it is the reactivation. So the following relationship is in this patient. Okay, so what are all the abnormal findings in this patient? 61-year-old.
Yes, chronic bronchitis.
Morning cup productive or minimal sputum, but now there is yellowish sputum in it. Breathlessness on moderate exertion. Three hospitalization over the past year for respiratory infection. Cigarette smoking for the past 30 years. Oxygen saturation is 88% at rest to 84% with moderate exertion. Which of the following is most likely to be seen in this patient? Does emphysema causes pulmonary hypertension?
No.
Does can emphysema increase the pressure in the pulmonary arteries? Yes or no?
Can be.
I
Can
think
be
they can cause.
any
COPD can
a-
cause
Yes. Yes, COPD can cause
yes, can cause.
hypertension.
Yes.
hypertension. Pulmonary hypertension secondary.
Emphysema can cause, and what group it is? Group number
Group 3.
Three.
Group 3.
three.
Yeah.
So that means option number B is not the right answer, right? And we know in emphysema is obstructive lung disease in which the FVC, and FEV1 are reduced, right? So when the okay, and it does not affect the left ventricular compliance, it affect the right ventricle, right? Okay.
Yes.
The residual volume is going to increase or decrease in emphysema?
Increase.
Actually,
It's going to increase.
Mm.
And what will happen to the erythropoietin production?
Increased erythropoietin.
Increase. Erythropoietin production is going to increase.
Could be because of chronic hypoxemia.
Yes, due to chronic
Yes.
hypoxemia.
Yes.
Okay. So it's
How
secondary
did you guys
polycythemia.
figure out? How did you all figure out it was not bronchiectasis and bronchiectasis because of mucus?
It's bronchitis actually.
Why it is not bronchiectasis? Not because the age is 61. He has 30 years of smoking, and oxygen saturation is 80. He has a respiratory infection history, but anything other than that does not leading towards bronchiectasis. Okay, the most likely it is going to be bronchial. Even if you think it is bronchiectasis, the answer will still be C. Even if you think it is
Yes,
bronchiectasis.
agree. Yeah. Yeah, obstructive. Yeah.
Okay. So I was saying you can see that there is secondary polycythemia in COPD. Okay. Which of the following is the most likely diagnosis here? CT scan shows multiple bilateral nodular lesion. Cherry red slightly raised lesion. Biopsy of the lesion is shown in the image below. Which of the following is the most likely diagnosis here? Okay. 61 HIV, cough, hemoptysis, COPD. Bronchus was a cherry red slightly raised lesion. This is a little bit difficult question. There is an HIV infection going on. There is a COPD, and the lesion is cherry red, slightly raised lesion.
The
Okay.
diagnosis is actually Kaposi sarcoma.
Yes. It could be everywhere in GIT, in lungs, in
Because cherry
Actually,
red. This remember this name, cherry red, and whenever you see it is an opportunistic infection, you will see in HIV patients. Okay. Hepatic. Kaposi sarcoma. Here it is written Kaposi sarcoma, occurring when the CD4 count decreases from the HHV8 and the HHV8 human herpes virus.
Why are the
Dark,
Yes, violet color lesions, violaceous.
violaceous dark plaques or
Dark.
nodules.
Mhm.
Kaposi sarcoma is a neoplasm of endothelial cells seen in HIV and AIDS. Okay, because you can see the bronchoscopy shows a cherry red, slightly raised lesion. Okay, you will not see a slightly raised cherry red lesion in carcinoid tumor or adenocarcinoma because most of the people will go with squamous cell carcinoma, or because in that types of cancer you will not see a raised lesion on bronchoscopy. Okay, that's why this question is a little bit difficult, because if you do not have read this in your microbiology, then this question will be a little bit difficult for you. Okay.
it can invade the mucosa as well as it can occur on the skin as well.
Yes, it can also invade the mucosa. That's why you are also seeing hemoptysis here. Okay, because it is invading the mucosa and causing the bleeding here. Okay. Kaposi sarcoma, human herpes virus, HIV, corticosteroid, hemoptysis due to tumor bleeding, endobrachial to the cherry red or violaceous, spindle cells, shaped endothelial cells, and slit-like vascular spaces. Okay. 33-year-old man comes to the emergency department due to 3 days of shortness of breath, profound fatigue, and chills. The patient has a history of intravenous drug use. He was enrolled in methadone. Okay. So this photo, see this photo? Okay. You can see the shape is wedge shape. Okay. Okay, then what is the most likely diagnosis here? Okay, so
these are actually the wedge-shaped pulmonary infarcts.
yes,
Segmental,
red-shaped
yes,
infarct.
infarction.
This is a red-shaped infarct. Occurs myocardial for you, red infarct. A red infarct, type of infarct, it is written in general patho, occurs in venous occlusion and tissues with multiple blood supplies, liver, lung, and with reperfusion as well. Okay, reperfusion injury is due to damage by free radicals. It is occurring due to the venous occlusion. Okay, due to pulmonary embolism. Okay, you can see there's a red infarct here. Okay, this is the red infarct. Okay, it is in the lungs. Okay, so what will be the answer in this? The red infarct is due to what? These wedge-shaped red infarcts are due to
Choices.
say due to C, severe small airway obstruction,
No.
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 due
Venous.
to tricuspid valve endocarditis.
No.
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 Okay, okay, so due to miliary tuberculosis.
No.
No.
Okay, so I want to note you. What is the temperature here?
40 is raised. I think it's
10.
endocarditis.
Yes, 104.
Yes,
The patient
endocarditis,
has
I
a
guess.
3-day situation and it is an intravenous drug
IV drug
user.
abuse.
And the temperature is higher. So we have to select an answer which is leading towards an infection. Okay, so aneurysm is eliminated. In venous thromboembolism, you will never see 104-degree temperature. Never. Okay, so we are left with miliary tuberculosis and tricuspid valve endocarditis. And now seeing the patient presentation, 3 days history of shortness of breath, profound fatigue, intravenous drug user, methadone program was enrolled, temperature was very high. Okay, and the most likely answer is going to be
D.
tricuspid valve
D.
Tricuspid valve, yes. IV
Endocarditis.
drug user, they involve right-sided heart valve.
Yes. Okay. These are red wedge-shaped infarcts which are seen in embolized. Okay. Let's move on to the next one. Lung biopsy, node biopsy reveals non-caseating granulomas. Okay. Non-caseating granulomas. Which of the following is the most likely cause of the elevated calcium in this patient? Read the whole question. Non-caseating granulomas are specific for what disease?
Sarcoidosis and
Sarcoidosis.
stimulate.
And in sarcoidosis, is the calcium levels are elevated?
Yes, elevated.
The calcium level, what is the cause of the elevated calcium level?
It's
Alpha 1
Activation of
hydroxylase
that
alpha
secretes alpha 1 hydroxy.
that is produced by active macrophages.
Yes, extrarenal alpha 1 alpha hydroxylase stimulation.
Vitamin D activation Y due to increase 1 alpha hydroxylase where in the macrophages. In the macrophages. And read the other part of the question as well. 35-year-old woman, emergency department due to fatigue, exertion, dyspnea, cough, but no upper respiratory symptom. Unremarkable. Physician shows normal air exchange with scattered V's and crackles and V's. Non-tender cervical lymphadenopathy, calcium levels are elevated. Scattered nodules. Okay, so what would be the answer then?
B.
B, activated macrophages, right? This sarcoidosis. Let's move on to our last question. Which of the following is the most likely explanation in this patient? In this patient's pulmonary symptoms. Is it atelectasis?
No, no.
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 No. Very good. You can read the whole question. It is not atelectasis, right? So option A is it pulmonary edema?
No, no,
No.
no,
Okay, left ventricle failure is also not the answer. Pulmonary hypertension does not appear as like this, right?
no, no.
No.
We are left with obstructive lung disease and
Yeah, no
pulmonary
obstructive lung
fibrosis.
disease. It is the interstitial
Yes,
lung disease.
fibrosis.
Yes, it
Pulmonary
is.
fibrosis. Yeah,
It is pulmonary fibrosis. Okay.
fibrosis.
58-year gestational dyspnea, started 6 months. Rheumatoid arthritis. He does not represent shows consistent with rheumatoid arthritis. Just as is shown in this photo. Okay, reticular there is opacity is here. Okay. Okay, so the answer is
Pulmonary fibrosis.
fibrosis. Okay, pulmonary fibrosis it is. Okay, so it is pulmonary fibrosis. Okay, so this is all for today. I think so. We are done with the. I will see how many questions are left of patho and pathophysiology. Okay, after that we are going to start the. Okay, do you also people want to do the micro part of the pulmo?
Yes.
Yeah,
Or do
yeah.
you want to do the micro part separately when you are doing the micro?
I think with the respiration, it's better.
Because if you haven't studied the micro, it will be going to be a little bit difficult for you.
Some of us
Okay.
haven't studied Dr. Micro. It hasn't been covered for
Separately is
some of
better.
us.
Yes, separately
Yeah.
is better.
Okay, but we can do immunology and histology and genetics of the pulmo. Okay, because
Yes.
I think so. There are 36 questions for the microbiology specifically for the pulmo, and that is like
Yes.
one complete block.
Better know there is a association with all these,
We can do
disease.
in one day. Yep.
Yeah.
We can do in you can do in one day, but it will be because you haven't. I will tell you the topics which you need to do for before starting the micro.
Yeah, you can tell
Usually the
topics we can
fungi
read from them.
infections. Most of the questions are regarding the fungi, and some are regarding strep pneumonia, and the other one are regarding the pneumonias. Okay, so I will tell you the topic. If you study those topics, then we can do the a, micro as well. Like you have to study 3 to 4 pages of micro. If you done 3 to 4 pages of first aid from micro, then we can do. Okay. Otherwise, you can do the micro when you are done with the microbiology part, and then you can do the block of microbiology. Okay. Just let me know which one do you people think would be suitable for you. Okay. After done with the after we are done with patho and pathophysiology, we will start pharmacology of the eh, of the pulmonology. Okay. So this is all for today. Okay. So Allah Hafiz. Bye-bye.
Okay. Thank you. Thank you.
Okay, so leave the meeting so we can download the whole of this
Yes, sir.
and upload it. Okay.
Thank you.
Thank you.
Hi. Hi. Are you there? Hi. Bye. Bye.